Okay, I can still see quite a few people are joining now, so I'll just wait one more minute before we start. Okay, it's just gone 1 o'clock now, so I think we'd better make a start. Hi, Irfan, you just said you're joining from Bangladesh. I don't know what the time is there, but I suspect this might be not 1 p.m. for you, so thank you for joining us. Okay, welcome to the ScHARR mini masterclass. Today we've got Dr. Andrew Lee. I'm Claire Beecroft. I'm the Deputy Director of Learning and Teaching at ScHARR, and I'm sort of hosting and moderating these mini masterclasses. So today we have Dr. Andrew Lee, who's going to be talking about public health in action, pandemic response to COVID-18. Before we start, I just want to go through some just sort of basic information about how you go about posting questions and what have you in Blackboard Collaborate. So I'm just going to share a slide that hopefully will look like what you're seeing on the screen more or less. So if you want to ask a question in person, so to speak, you'd need to enable your microphone, and to do that you click on the teeny weeny little microphone image, which probably has a slash through it at the moment. That would be to make yourself heard. We will do the questions at the end though, rather than during the session. If you wanted to, you can switch your webcam on as well. Again, you just click on the little video icon to activate that. And if you wanted to raise your hand to sort of get our attention at any point, you click there. Probably more usefully during the session today are the chat functionality. So in the bottom right hand corner, you should see a little purple tab, and if you click on that, this white panel move out from the right hand side. And in there, the little bubble will open up the chat box. So in the chat box, you can post questions. Everyone, including me, can see your question, and we'll be able to respond to your questions. Like I say, we'll mainly do that at the end of the session. But if you post your questions in there, and then I'll sort of pick through them and read them to Andrew. You can see a list of the attendees and the little icon of people. And if you're having any problems with your microphone or your camera or anything like that, the little cog will open up the settings feature. And there you can make sure that you've chosen the correct microphone, etc., in order to be able to be heard and hear and everything today. Okay, so I'm going to load up Andrew's slides and then just tell you a little bit more about him. So Andrew trained in medicine at the University of Edinburgh, and following paediatric and tropical medicine training, he worked overseas in Afghanistan, working in primary healthcare and tuberculosis control programs. He trained in general practice and public health in the UK, and has worked in Nottingham as a public health consultant, and with Public Health England currently in the Yorkshire Humber region. sorry, that's not currently, I know that was in the past, I apologise, with a remit covering health protection, sexual health and learning disabilities. He's currently the Executive Director of Primary Care and Population Health with the NHS Clinical Commissioning Group in Yorkshire, and he joined ScHARR in the section of Public Health in February 2008, so I think that's just a few years after I joined. So Andrew within ScHARR is a reader in global public health. He does quite a lot of teaching for us and has done over the years, and he's been repeatedly nominated for ScHARR's annual teaching award, and I think he's won it certainly once and possibly more than once. And his teaching is hugely popular with our students and very much esteemed by his colleagues, including me. His research interests include health protection, including disaster response, emergency planning and control of communicable diseases, all very relevant at the current time, and obviously why he'll be speaking about COVID today. And he's also has research interests in health service management. In recent months, he's appeared in local and national media, including BBC Look North just this week, and also is quite active on Twitter and has been helping the wider public, I think, to understand how public health practice responds to the COVID-19 pandemic amidst a backdrop of some quite confusing messages and sometimes quite sensationalised reporting in the media. So I'm going to hand over to Andrew now, and then once his presentation is finished, then we'll go over to the chat and we'll have some questions at the end. But it's fine to post your questions in the chat throughout the session at any time as the thoughts kind of come to you, and then we'll deal with the questions at the end. So I'm going to disable my camera and mic now and hand over to Andrew.
Thanks, Claire. I must say, you've just made it very difficult, isn't it, with such an introduction. Hi, everyone. I hope you're all well, wherever in the world you are. And thanks for giving up some time to come and listen to me talk a little bit about COVID. I think none of us can really escape COVID, can we? It's all around. It's so pervasive now in life. Okay, so I was going to start with this first slide and talk about infectious diseases in general. It's amazing. There are 15 million people every year dying from infectious diseases. And this represents a quarter of all deaths worldwide. And many of us take that for granted in the antibiotic era. We think, oh, well, infectious diseases, that's something in the dim and distant past. But clearly not. It's still here. And it exacts a terrible toll for people at the extremes of life. You know, so the very young, those under 5, as well as the very old. But don't forget, it doesn't mean that any of us in between those two age range can't get infected. We can. The thing about infections, there are thousands happening every day out there in the community. Okay, not all of them will present to a doctor. Not all of them will be diagnosed. Not all of those that have been seen by a doctor or diagnosed are notified. So if they're not notified, they are not captured in the surveillance data. So we don't always see. So we don't always know just how big that burden of disease is for infectious disease. We always only ever see the tip of the iceberg. And that's true for COVID as well. So in the next few slides, I'm going to talk you through some basic principles around public health, communicable disease control, and we'll feed into the current pandemic, COVID, and see how it all fits in. All right. So the next bit to bear in mind is that communicable disease, infectious disease, they don't happen at random. People think they do. It might appear that they do, but they don't. And if we had magic goggles that will allow us to see how infections spread out in the community, unfortunately we don't have them, we would be able to see that infections follow a chain of transmission, a pathway, so to speak, for infections, okay? And these infections are caused by viruses or fungi or bacteria, whatever. Or they're caused by these microorganisms that exist in reservoirs. Some of these reservoirs are animal reservoirs. So if you think flu, it's pigs and birds and seals and dolphins that are the animal reservoirs for flu. And some of these reservoirs are environmental reservoirs. Okay, so again, if you think of Legionella, which causes Legionnaire's disease, it exists in warm, stagnant water out there in the environment. And some of these diseases, the reservoirs are humans, people with chronic infections like hepatitis B, hepatitis C, HIV, malaria, for example. And these horrible, nasty little things, these pathogens that cause disease, they've somehow got to get out from these reservoirs, and they come out in, let's just say, blood or urine or some other bodily secretion. There's a mode of transmission, how they are passed on to the next person, and they've got to get into the next person, the susceptible host. And this could be through breathing it in, drinking it, eating it, and so forth, okay? So there's a portal of entry into the susceptible host, and then it's got to get out again. The pathogen's got to get out again from the host, back into the reservoirs and circulating out in the population. The reason why this chain of infection is important to know is because it allows us to identify ways we can stop infection spreading. Anywhere along this pathway, anywhere here, we can put in measures, break the chain of transmission, and that'll stop it dead, okay? So whether we eliminate the reservoirs, or we stop the mode of transmission, or we protect the host, there are very, very different ways that we can work to try and control that spreading. Let's have a look at some of the ways we can spread diseases. So for them, some of you who have listened to my lectures before, you will have heard me say this, okay? Contact. As a human species, we like contact. It's probably inbuilt into our DNA. We'd like to have human contact, whether it's shaking hands, hugs and kisses and all that kind of stuff. But close contact with people enables the transmission of pathogens, okay? Imagine dirty hands. Or sometimes the pathogens contaminate objects, okay? Like door handles or chairs or tabletops, okay? Well, something we call fomites. And again, contact with these surfaces may allow the transmission of infection. Examples of diseases that are spread this way include stuff like scabies, head lice, but also think of viruses like your hand warts or the sexually transmitted infections. And then there are vectors. These are often insects that transport the virus or the bacteria. I hate mosquitoes and I hate flies. You know, the mosquito, they transmit loads of different infections, you know, from Japanese encephalitis B to malaria, yellow fever, Zika, chikungunya, nasty little thing. And the flies themselves can pick up germs wherever they land. So just think about it. You know, they land on some rotting stuff out there or some brown human excrement, and they fly away, and then they might land on your food, something you eat. So they act as the taxi service for germs. Okay, and there are also other insects like ticks that can spread tick-borne encephalitis, for example. But not all vectors are insects. Some vectors are mechanical, like syringes, okay, dirty needles. And many of you will know of the infections that are spread through dirty needles, like HIV, hepatitis B, and hepatitis C, for example. It's not just drug users who may come into contact with these contaminated devices. Think of tattoos, okay? So the next time you decide to go and get a tattoo done or get your ears pierced or some other body part pierced, just ask yourself, how clean is that implement being used on yourself, all right? Okay. And relevant to today's talk is around COVID. It's about airborne spread, okay? So this is where we breathe stuff into us. There's been a lot of academic arguments at the moment as to whether COVID is an aerosol or droplet spread. Now, droplets are fairly large droplets, as you can imagine. They're about anywhere from 5 micrometers up to 100 and bigger. So in this picture, what you can see, those big globules of spit and stuff coming out from this chap's mouth, those are large droplets. But at the other end, so it's a spectrum, at the other end are the tiniest droplets. Sometimes we call them droplet nuclei, less than 5 micrometers in size, that can also contain virus. So just think of aerosol spread as little droplets. Big droplets don't travel very far. Yeah, it's like, can you imagine trying to throw a bowling ball? You can't throw it very far, okay? So it lands within 1 meter or 2 meters away. And we think this is primarily the main mode of transmission for COVID. But you've also got aerosol, and these are the tiniest droplets, and they can stay suspended in the air. And some studies have shown that these tiniest of droplets can last up to 40 hours, so nearly 2 days suspended in air. Clearly, when the droplets are really, really tiny, the amount of virus in them is a lot less. So potentially the ability to infect someone is a lot less. Okay. In my mind, whether it's droplet spread or aerosol spread doesn't matter. The point is, a lot of the infection control measures we need to do are the same. So watch your distance, wear a mask, wash your hands, all that stuff. Okay. So moving on. So, as you heard from Claire, I used to work for the Health Protection Agency and Public Health England as a consultant in communicable disease control. And it's a cool job. So for those of you who are ever interested in doing public health, it's a cool job to do, because we are bug detectives, infectious disease detectives. And our jobs is to go out and try and find people who are infected with disease, try and confirm they've got an infection, so do that diagnosis bit, and then look for other cases that may have been infected, and do something we call contact tracing, all right? And contact tracing is about looking for people who have come into contact with people with infection. Yeah. So it's a bit of shoe leather detective work, a lot of phone calls and trying to track people down and see where they've been and find out what they've done and the potential risks. Okay. I always tell my trainees and classes, when you think about an infectious disease, it's dead simple. You just have to think of 2 bits if you're trying to control it. Okay. Where the heck has it come from, and where is it going? Okay, there's always a source. There's always a source for the infection. Remember, it's not random, and it's going to go somewhere. So let's look for the receptor. Okay. So your job as an infectious disease detective, you start with the person in the middle, and then you work backwards to try and work out where they may have picked up that infection from, and then you try and work out where they may have passed the infection on to. Yeah. We're trying to identify who's at risk. So it's not just the people who may have come into contact with that case, because risk also involves potential settings. Risk also depends on the characteristics of the people. It might be an age group that's at risk, an ethnic group, it might be an occupational group. So we'll come back to this as well a little bit later when we talk about COVID. And once you've found your cases of infection, some of you might have heard the UK Prime Minister describe disease control as a game of whack-a-mole. Yeah, I don't know how many of you have had the chance to play whack-a-mole. That picture on the right, where you get the little coming up and you have to whack it with a hammer. And the nicer picture I prefer is the one on the left. And this is where you've got firefighters up on the moors in the north of England trying to beat out bushfires as they appear. And that very much is how communicable disease control teams work. They try to look for the infection and they try and squash it out and stamp it out before it's had a chance to spread too far. Now, we may see little sporadic cases of infection. This is 1 or 2 appearing all over the place. And we play this game of whack-a-mole. As I said, we're trying to beat them out. And hopefully we're successful at that. But if we are not, then we start to find more and more of these sporadic cases appearing. So when you get lots of sporadic cases appearing, we call them clusters. And what is important about a cluster is we have not found the chain of transmission. How is one case linked to the next? But when we can find 2 or more cases that are somehow linked, we then know we've got an outbreak on our hands. Yeah, and this outbreak, it could be linked because people went to the same restaurant, let's just say, or attended the same class, or in the same workplace, or sat in the same bus. Or maybe they ate the same dodgy burger or food item, okay? Or maybe they were in close proximity to one another for a duration of time somewhere. So when you start having outbreaks, that's worrying. And that's where you've got to go in and really try and control the outbreak, stamp it out before it's a chance to spread. There's a term we call epidemics. And basically what an epidemic is, are lots and lots of outbreaks. So when we talk about an outbreak in Britain or Bangladesh or Melbourne, for example, we're talking about lots and lots of outbreaks occurring in that setting. Okay, an epidemic is happening there. And when that epidemic is spreading through the community, so you've got community transmission, then we've got a pandemic. And that's certainly the case we've got with COVID. And the next question we've got is, what happens about endemic disease? Have we reached the point where we can't get rid of the outbreaks of that particular disease? When that happens and the disease continues to burn and spread and simmer out there in our communities, that disease has become endemic. It's taken root. I think we still got a chance globally to try and stop COVID becoming endemic, but there are parts of the world now where that opportunity is fast diminishing. So we are at a very critical time point, I think, in the evolution for our global pandemic of COVID. Okay. And how do we play whack-a-mole with them? I said, what can we do to stop them? And a lot of the measures here are pretty standard. Hygiene, and you'll think, oh gosh, hygiene, wash your hands. That's what your grandma told you to do, isn't it? But don't dispute that, okay? Don't play it down, don't poo-poo it. The humble bar of soap is very powerful. It's fantastic against lots of bacteria, but it's also fantastic against viruses that have got a fat covering, a fat envelope, a lipid envelope. And guess what? The coronavirus has a lipid envelope, yeah? So it's actually quite susceptible to hand washing. I mentioned social distancing earlier, okay? So for diseases that spread through airborne routes, for example, you want to keep distance. And the way to think about it, coming back to COVID, is imagine someone smoking. How close do you want to stand next to a smoker before you start to smell of cigarette smoke, before breathing in lots of cigarette smoke? And it's the same with respiratory virus, measles, COVID, okay? You don't want to be too close. And the further away you are, maintaining that distance, the less likely you are to inhale all the smoke or toxins or viruses that are spread in this way, okay? And if someone's ill, it's so important to isolate them. I don't know about, for those of you from outside the UK, in Britain, we've got a funny social norm. It's called presenteeism. People feel they need to turn up to work, even when they're at death's door and dying and coughing their guts up, okay? Not the best idea if you've got an infectious disease. You really want people to keep the distance, stay home until they get better, rather than going into a classroom or into an office space or a factory and infecting people. Isolation works. Isolation is important. Then there are personal protective equipments we could use, like face masks and hand gloves and aprons and all that. In the case of COVID, what we know is face masks are pretty good at capturing a lot of the droplets coming out from an infected person. So whenever we wear face masks, it's to protect the source, to stop the source, from spewing out lots and lots of virus and droplets that someone else may inhale in. Okay, so sometimes these equipment help protect the spread and stop the spread of infection. For some diseases, if you treat the person, you get rid of the bugs or germs in them, that's it, you're no longer infectious. So treatment can be pretty potent as prevention. And we see this with diseases like hepatitis C, tuberculosis, malaria. Yeah, if we treat someone with malaria, there's no malaria there, there's no human reservoir for the disease. Chemoprophylaxis describes taking antibiotics before you're exposed, or if you are exposed to an infection, to stop you getting it. And we've all heard, and we should all know about the value of vaccination. So these are just some examples of countermeasures that we can take into hand. All right. Now I want to go back in history a little bit, and let's just talk about flu. So way back in 1918, when Spanish influenza first appeared, okay, it took months to spread around the world, but it was pretty potent. Within a few years, it killed 40 million people. It led to a contracture of economic activity equivalent to the 2008 financial crash that we've seen. It was pretty nasty. And when you look at the pictures taken from back in 1918, they're not too dissimilar to now. You know, if you think about the mass hospitals that have been set up, the Nightingale wards in the UK, and pictures of people wearing face masks, all that has happened and will happen again. And we've had further outbreaks of flu pandemics. We've had in the 1950s Asian flu, in the 1960s Hong Kong flu. We've had swine flu in 2009. So flu has a periodicity to it, and will come back again and again. And the risk of another flu pandemic is not gone. What's also telling about these pandemics is that when they come, they sometimes come in waves. And the flu waves back in 1918 came in 3 waves. This is indeed a worry for us now with COVID. We are anticipating that we've just got past the first wave and we may be heading for second or potentially even third or fourth waves in due course. Certainly in the US, some may say they already have had their second wave. In Israel, they have seen a second wave. In Iran, they've seen a second wave. Okay, so watch this space, more waves to come. And we actually had some warning signs about COVID, warning signs that a pandemic risk was there. Back in 2003, might seem a long time ago, but it wasn't, okay, when we had the first coronavirus pandemic, SARS. Infected 8,000 people around the world and led to 800 deaths. It infected countries all around the world, yeah? And what we learned from them was that just like we can travel on a jet plane, so can all these bugs and viruses. And SARS-CoV, the very first one back then, traveled. And this is a picture of air travel around the world. It's a heat map. And you can see a lot of the heat starts in the Far East, heads across to Western Europe, heads across to North America. Yeah, we've seen this same pattern with COVID. We've seen the same pattern with COVID. It's not surprising that the first waves of COVID struck Western Europe first and the US, and went to Africa, South America much, much, much later. It's just simply a phenomenon that they were further away from a lot of the air travel routes. In fact, some academics in the early months of the COVID pandemic thought that, Africa and South America were spared because they had some special unique characteristics about them. Turns out that's not the case. Currently, the country with the highest number of daily new cases is India, as well as Brazil, Peru. So many of our Sub-Saharan African countries, South American countries, South Asian countries are now coming to the forefront of infection. Okay. The other thing we learned from the first SARS pandemic, so to speak, was the phenomenon of super spreading. And this is where a few people account for most of the infection. This is a report from Singapore, and they just showed that 5 people accounted for more than half of all their cases, as you can see with the diagram. Yeah, this is true not just for SARS. We've seen it with measles, we've seen it with flu, and we are seeing it with COVID. Okay, what we somehow don't know yet is how to identify these folk. And I think there's a Nobel Prize out there for someone who can identify a means of identifying super spreaders. Okay, it's said that 80% of infections are spread by 10 to 20% of people. Okay, and SARS, what SARS showed us was that our international health regulations don't work very well. Some of you might be wondering, what the heck is an IHR, International Health Regulation? Do you remember back, those of you old enough, you go back 10, 20 years ago, if you were on an aircraft, you'd have the air stewardesses going, ladies and gentlemen, in accordance with international health regulations, I've got to spray all of you with a deadly insecticide. And then you'd have the air stewardesses walking down with spray cans, spraying everyone. That's an example of IHR. And that measure was to kill mosquitoes, flies, whatever insects could be on those aircraft. And it was a means of trying to stop infections. But the IHR was outdated back in 2003 when SARS first appeared, because it didn't put a requirement on countries like China to report new outbreaks of infection, because the IHR was limited to a very small number of infections only. And it was very reactive, okay? It was very reactive. It was trying to stop infections at borders rather than controlling it at source. So the regulations were reformed, led by the WHO. And now they were focusing on hitting infections where they occurred, stopping it in its track before it had a chance to spread. And we've seen it work. We've seen it work for diseases like MERS, for Ebola, for Zika, and even with swine flu. And that's where the new IHR led to the world trying to control diseases at the point of origin before it's had a chance to spread. Okay. I mentioned MERS. And again, MERS is another cousin of SARS and the COVID virus. And this appeared back in 2015. It took one person, one traveler from the Middle East going back to South Korea, who managed to infect 186 other people. And again, this demonstrates the super spreading phenomenon. But the other useful learning from here was that a lot of infections were concentrated in healthcare settings, in hospitals. Okay, so I hope you're getting a sense now that even before COVID struck, we already had a lot of lessons learned from previous pandemics and outbreaks and epidemics of how this pandemic could behave. Okay, indeed, the world had got plans in place for pandemics. The picture on the right shows a risk matrix in the UK for the UK government, and the top arrow in red there points to pandemic influenza. Therein lies the problem. In Britain, we were preparing for pandemic flu, not pandemic coronavirus, which is the yellow arrow down there. We thought something like coronavirus was a lot lower risk and less likely to cause issues. So we didn't quite prepare for it. All our planning was for flu. And coronavirus is not the same as flu. Coronavirus is not the same as flu. Therein lies the problem. With flu, we have some medications that have some effectiveness. Okay, and on top of that, we also have vaccine development programs for flu, which are quite advanced. We know how to make flu vaccines. So had there been a flu pandemic, we would have been in a better place to respond to it. Whereas with the coronavirus, we almost basically had to start from scratch. So let's fast forward to this year. You all know this, yeah? It all started in China, we think, okay? It probably originated in bats, but remember I mentioned to you reservoirs? There are other reservoirs for SARS-CoV-2, including the humble pangolin. People have found that cats, domestic cats carry it. But whether these animal reservoirs transmit the virus efficiently, spread the virus efficiently to people, that's another matter. But somehow it did in Hubei, Wuhan province, yeah? And back in December, infections were linked to a seafood wholesale market. And before you knew it, China had a problem. In line with international health regulations, China informed the World Health Organization on the 31st of December. And by the 21st of January, the WHO alerted the world. Hang on, we've got an issue here. Okay, bear in mind the dates. 21st of January was when the WHO issued a situation report to the world that we've got an issue. But it was on the 30th of January, so this is more than a month after the first cases in China appeared, when the WHO declared COVID as a public health emergency, 30th of January. Now, you would have thought countries around the world would have gone, okay, the fire alarm is going, we've got to get out of the building and do something now. We should put up border control measures. We should get ready. We should start looking at lockdown and so on and so forth. And we didn't. We didn't. So one of the shames, the great shames really, for those of us in the West, in particular in Western Europe, North America, is that we didn't respond as quickly as we should have, as we could have. Whereas countries that had experienced the first SARS epidemic more than 15 years ago, places like Hong Kong, Taiwan, South Korea, Singapore, they reacted very rigorously and put in measures, really, really stringent measures, because they knew what it could do. I almost wonder whether, because of swine flu, everyone thought swine flu was a bit of a damp squib, so we didn't respond as rigorously as we should have. So that was the 30th of January. Fast forward 3 weeks later, most of the cases were still in China, about 24,000, but now we're starting to see cases emerge elsewhere in the world. Still not a lot elsewhere in the world. Fast forward again, 1 month on from February. So this is 2 months after the WHO has declared a problem, okay? And Europe's on fire. Interestingly now, when we look back, we know that the first cases of SARS-CoV-2, certainly in the UK, probably were already in the UK as early as January, if not before. Back in late January, early February, when the British government started to put up border controls measures, everyone was worried about travelers coming back from China, okay? But they missed the back door, because there were already a lot of infections at that time in southern Europe. And around the time of late February, it was the school holidays, there were lots of British travelers to and fro going across to southern Europe and bringing back the infection. So a lot of these infections were already spreading by then. At this point in time, the epidemiologists started to model what could happen, and they went, oh dear, we've got a problem. Oh dear, okay? They thought that we've got a disease here. Based on the rate of spread of this disease and its fatality, we could be looking in the UK at 500,000 deaths. In the US, that's 2 million deaths. Frightening stuff. I guess at this point in time, finally, the authorities woke up, came to the census and started to respond far more aggressively. And one of the things that they have set out to do, they've realized that you've got to flatten the epidemic curve. Flatten how many cases you've got, spread it out a bit more, because without mitigation, without trying to control the spread, it would exceed the ability of our health services to cope with it. So this was a strategy called flattening the curve. Yeah. And they were looking at all the different potential measures that could work. Okay, if we did nothing, we'd have lots of people ill. We could start isolating people. That would help a little bit. Yeah, probably reduce the numbers by about a third. What if we did household quarantine as well? So not just the person who's infected, but anyone in their household, quarantine the whole household. And say, yeah, that works. It gets the level down. And then if we close schools, it'll get the levels down a bit more. And if we do social distancing of everyone over the age of 70, it reduces the epidemic curve even more, flattening the curve. The take-home message for you here is that all of these measures work together. They're additive, they add up. So in an ideal world, we should do them all. But there is a problem, isn't there? The problem here is, can you maintain it? So for those of you in the UK and certainly other countries, we've gone into lockdown. But lockdown is something you can perhaps sustain for a few months, but not indefinitely. Can you put an entire country into lockdown? What are the social and economic costs? What are the impacts on people, on the elderly, on the isolated, on people with disabilities, on school children? So lockdown in itself is not a long-term solution. It will not get us out of the pandemic. Okay. Can we create and bolster and strengthen our health protection systems? And here's what we probably needed to do. Public Health England was probably the front line, the tripwire for the country. And they did a lot of this detection stuff, the testing and the tracing, trying to get people to isolate. But their resource at the start of the year was pretty slim. In fact, over the last decade, they've had their budget slashed and slashed and slashed right down. So their capacity was much reduced. It was the same for many public health agencies around the world. In good times, most governments think, oh, public health is a waste of time. Why throw money at it? Public health is like an insurance scheme, you know. And believe you me, when you need your insurance, you really need it, don't you? Yeah. So a lot of countries are playing catch up, trying to bolster their public health systems now to varying degrees of success. Okay. And this just shows the pattern that's happened in the UK. We've managed to flatten the curve, as you can see. Numbers have been pretty steady since, I guess, mid-June onwards, and we had the peak of all our cases and deaths back in April and May. I hope you can also see that there is a time lag between deaths and cases, about 7 to 14 days time lag between deaths and cases. All right, and that makes sense, doesn't it? Because when a person falls ill, they're not going to die straight away. Most of the deaths happen 7 to 10 days into an illness. So what have we learned? Firstly, speed of response matters. It really does. You will all have heard of the concept of the basic reproductive number, or R0. And this is an inherent property of any germ or virus or bacteria. And it is the number of people on average that this pathogen would infect. Okay, for every infected case, how many other infected people would it infect? There will be factors that determines the number. And when you start putting in control measures, isolation, hand washing, and all that kind of stuff, the reproduction number drops, and the number of people you'll infect drops. I've put the table on the right here so you can see where COVID fits into the grand scheme of things. It's more infective than flu, yeah, more infective than Ebola, okay, but a lot less infective than measles, thankfully. Nonetheless, still pretty infective. And in some certain circumstances early on in the year, the reproductive number was reported to be as high as 5.8. But look at the case fatality rate. This is the proportion of people with the infection who die. Something like flu, it's pretty low, it's 0.1%. In SARS, we think it's about 0.8%, but it varies again. So in some developing countries, it's as high as 4%. And again, within certain age groups, it's much higher. And again, with SARS, you can see it's got a wider range, similarly with measles. Yeah. The reason why speed matters is because this disease infects lots of people, but also we know that some people are infectious 2 to 3 days before they show symptoms, what we call asymptomatic spread. Okay, so they start to spread infection even before they develop symptoms, the pre-symptomatic stage. And some people never develop symptoms. They are asymptomatic throughout. They have got no symptoms throughout, but yet they spread diseases. Okay, and lastly, I mentioned super spreading, and there have been several super spreading events reported around the world. There was a choir practice in Skagit in Washington State in the US, where a choir turned up, 60 people turned up, and 50 odd got infected. There was a restaurant in China, again, where a large number of them got infected. Similarly, in South Korea, associated with nightclubs, there were lots of infection spread in those settings. Okay, moving on. So what are the risk factors for death? So we know that AIDS is bad for you. The older you are, the risk of death is higher. Interestingly, men are more likely to die than women. So yet again, this shows why being a woman sometimes is advantageous in health terms. We know obesity is a risk factor, partly around the difficulties in ventilating people who are obese. And we know that people with certain health conditions, especially those with cancers, bone marrow problems, for example, are at very high risk of death. Okay. The bit that has got lots of people worried are, what about children? And I'm sure many of you will have children as well. Some of your kids will be going back to school, and you're thinking, oh dear, what's the risk to our kids? The studies so far, certainly that from the UK, and this is backed up by studies from elsewhere like China, shows that the risk to children is exceedingly low. So the risk of death in children aged 5 to 14 is 1 in 3.5 million. Okay, so you're more likely to win something on the national lottery than you are to die from COVID if you're a child. In fact, children are more likely to die from influenza or get hit by a bus or have a road traffic accident than actually die from COVID. So the risk to children is very low. But as they age and they become teenagers and young adults, then their risk starts to rise. And by the time you're an elderly person, the risk of death, if you're over the age of 90, is 1 in 55. Okay, so the risk to children, pretty low. We know there's an ethnic minority bias here. Studies from the US and the UK have shown that. Okay, so people of Black, African, Caribbean heritage, for example, in this country, as well as the Asian groups, have a higher risk of getting the infection and dying from it. Now, although we don't quite exactly know what the reasons are for this, it's clear that structural racism has a part to play, because many of these folk from the ethnic minority groups, guess what? They tend to be living in more deprived areas. They tend to be in poorer housing and live in multi-occupancy housing. That means many people in the same house, for example. So the risks are higher there. And they tend to be doing the low-paid jobs, the key worker jobs, whether it's being a bus driver or working as a porter or a cleaner in a hospital or as a security guard. They are doing those key worker jobs that are higher risk. So it's perhaps no surprise that the risks of infection and death in these ethnic minority groups are so ingrained. Yeah. We also know that there are lots of risk settings. So right at the very top, households. Okay, if you've got one person infected in your household, there's a high risk that others in the household will get infected. A paper I saw yesterday put that risk of infection to other people in the household around about 1 in 3. We also know that there's a risk of spread in workplace clusters. So if you're in a garment factory, a food processing plant, and so forth, your risk is higher. We know that hospitals and care homes are high risk. And again, this is not news. This was the case back in SARS in 2003, for MERS in South Korea in 2015. We know that hospitals are high-risk settings, okay? And we know there are links with deprivation, as I mentioned earlier. More importantly, there are super spreading hotspots. Anything that you've got a mass gathering, a nightclub, a choir, these are all high risk. And you might be thinking, why is a choir high risk? And there's a physical explanation for that. Studies have shown that when you sing, your risk of blowing out, aerosolizing viruses increases tenfold to if you were just sitting quietly and just breathing normally, increases tenfold. And if you're shouting, it goes up 50-fold. So just imagine a loud, noisy, jam-packed nightclub, and lots of people in there and everyone's shouting at each other. Yeah, guaranteed way to spread diseases. Okay, so the potent enablers of disease transmission: close contact, crowds, confined spaces. And the bit about confined spaces also has to do about ventilation. All right, remember the analogy I told you earlier about cigarette smoking. Okay, if you're outdoors with someone who's smoking, chances are you won't smell much of the cigarette smoke. But if you're in a tiny room where the ventilation is poor and someone is smoking in there, the whole room would stink up, it'd be full of smoke, and you'll smell of smoke and you'll breathe in lots of smoke. Yeah, ventilation is key. As an environmental health colleague of mine once said, the solution to pollution is dilution. Yeah, so ventilation is good. So many of you will know Tedros, the Director General for the WHO, and right throughout he's been encouraging countries to test. And he's right in a way. We need to be able to find those cases, find those people who are infected out there. Yeah, but please bear in mind that there's no such thing as a perfect test. I think it was in the last couple of days, the British Prime Minister has described his moonshot idea to introduce millions of tests for the population at large. At this point in time, my personal view is that that's not logistically feasible, but there are also lots of flaws because there's no such thing as a perfect test. Tests will give you false positives and false negatives. People who are false positive may end up being isolated or having their lives disrupted unnecessarily. They'll have lots of anxiety and worries. And then people who are false negative think, I'm fine. I haven't got an infection because the test says so, even though they might be infected and going around and infecting the lot of you. Okay? So be careful about tests. You've got to interpret the tests. You've got to interpret the tests. Clinical interpretation is important. And it has to be plugged into the health protection system, the public health system. So if you find a case, that the disease detectives can go out there and investigate it and trace it and make sure that control measures are put in place. All right. Okay. So there are no magic bullets, unfortunately, for COVID. From all the studies that have been done around the world, from our practice at the front lines, okay, what we know is that maintaining distance is important. What we know is hand washing and face coverings helps. Yeah, face covering reduces the spread, definitely the spread of infectious airborne droplet spread and so forth. We need to avoid crowds, contacts, confined spaces. You all know that. But there's a very important message here. I already mentioned the issue of presenteeism. People who are unwell really have got to stay home. They really got to isolate. And this is a message I don't think is stressed enough. Okay, because just think about it. If you've got an infected person and you take them out of society, you've straight away broken that chain of transmission. Okay, so these are things we can do. These are things that we can do. Okay, I can't do a COVID talk and not talk about this chap. For those of you who don't know him, this is Dominic Cummings, one of the government advisors. And the story goes, he broke the government's own lockdown guidance way back in April. And this had a detrimental effect on public trust. There's an issue here, especially in Western democracies, in particular, such as the UK, the US, and so forth. We need public trust in order for people to comply and follow guidance. But when the public's trust is lost, people don't follow guidance, people don't follow advice. There was a worrying survey out a couple of weeks ago, which showed that in the UK, only a quarter of people with COVID symptoms complied with advice to stay home. Isn't that scary? That means 3/4 of people with COVID symptoms who are infectious are ignoring public health advice and are out there. Okay, so it shows why compliance is important. In comparison, there was a study from China which showed that public compliance with lockdown was 95%. So compare and contrast, 25 versus 95%. Yeah, I appreciate they are completely different social systems and government systems, but I'm trying to highlight the importance of compliance here. And public trust depends on transparency. Public trust depends on how well we, as public health professionals, communicate with the public and get messages across. It's about how we share information, but not just with the public, but also with other agencies that need to work on it. Okay, and if you ever come and study public health, one really cool subject to study is behavioral science. It really is. Understanding how people think, understanding how populations think. And what we know, for example, is if we introduce measures that are too draconian, people will try and game the system. They'll try and find workarounds, work a way around it. Yeah. So telling young university students not to go partying and have raves doesn't quite work, because lots of young people like to have a good time, and I don't blame them. Okay, so it's how do we get those kinds of messages out in a much more positive light. We also know that negative messages telling people, oh, it's all your fault that infection is spreading, doesn't work. Okay, it gets people's backs up. Yeah, people become defensive and they don't want to listen to you. All right, so having a positive message, having a message that we are all in this together, about appealing to people's goodwill and working for the benefit of others. Protect your granny. Yeah, messages like that, public behavioral science messages done right, can be quite powerful. Okay, it's important, if one thing you take away from today, for all of us to gain a degree of scientific literacy, understanding of the science, because there are lies, damn lies in statistics, and a lot of people struggle to interpret it. Yeah, the data we often see in graphs like this one from the Financial Times, these don't show all cases. Surveillance is a proxy. It only shows cases that are reported. So a proportion of the iceberg I showed you right from the start. And if you test more people, you'll find more cases. Yeah. And in every system, there's a bias in the system as to how systems record. So in this graph, I've compared 6 countries: India, Brazil, the US, Russia, UK, and China. But the testing practices in all these countries are different. So you might actually find that the true number of cases and deaths in India or Russia or Brazil are much higher than, say, the UK or China. The comparability is not always there. So be careful how you interpret information, right? Almost there. Just a few more slides. So this first one, will there be a vaccine? I think so. It's a matter of time. There are lots of vaccines in development at this point in time. I'm hopeful. Will the vaccines return us back to normality? Remains to be seen. That's the million-dollar question, okay? Because we're not sure how long the vaccine immunity will last. We're not sure how effective the vaccine immunity will be. So all these studies are still being done. So watch this space. I've put this one. For those of you living in the Northern Hemisphere, in the UK, winter's coming. And for those of us who work in the health service, we are worried. Because winter is always a bad month for respiratory viruses. We tend to get lots of respiratory virus outbreaks. We get flu, we get coronavirus, we get rhinovirus, a whole bunch of them, yeah? And what we don't know is what happens when you get flu plus coronavirus, okay? Might get so many cases that it overwhelms the health system. Might flu increase the spread of coronavirus? We don't know. So worrying times ahead, really, yeah? Now we're going to finish on this slide before we go to questions and answers, yeah? And it's just to say, if we looked at history, we knew that there was always a threat for an infectious disease emerging. Every decade we've had one of varying degrees. So for sure, going forward, there will be future infectious disease threats. It's only a matter of time. So governments, public health agencies, health systems, we mustn't be complacent. We mustn't be complacent. The risks are still there. And as I said at the very outset, the risk of a pandemic flu is still there. We may think COVID is bad, but believe you me, there are far worse pathogens out there. And on that very cheery note, I'll stop here and we'll go to questions and answers. Okay.
Okay, thanks, Andrew. I'm just going to track back to some of the questions that have been posed. Andy asks, how do you distinguish between a second wave and a resurgence due to changes in protective measures, public health behaviour, and does it even matter?
a jolly good question. To be honest, Andy, I think it's semantics. To all intents and purposes, we've already had a dip in our first wave for the UK, all right? So we've gone past the first wave. So whatever surges we're getting now, it's the second wave.
Okay, we have another question from, I think Ella was next, saying, do you believe that the current EU health laws, such as Article 168 of the TFEU, should be reformed to provide more power to the EU to coordinate public health responses?
Yep, I certainly agree with that. One of the nice things that Europe has is the European Centre for Disease Control, and they've had a role in trying to help coordinate disease response activities right across Europe. Not all the European countries have got the same level of health security, so their public health systems for infectious diseases are not so well developed. Some countries have much more robust systems, if you look at Germany, for example, but the other European countries where it's weak. So they do need a strengthening of their infrastructure and their responses and their resources in order to be able to respond to the threat across Europe. Yeah. But my final point, just to finish on that, is at the end of the day, the response and control of disease still remains the responsibility of the government of whatever country it is. Yeah. So although we may talk about an EU-wide, EU-level control system, it's still down to the individual EU countries to enact them.
Okay. The next question was from Lily, who asks, can governments or bodies such as the World Health Organization ever realistically be held responsible for acting too late, etc., or ensure that preparations are made to limit this from happening again at the same scale?
Okay, so hi Lily, this is quite a tricky question. So the first one is, can they be held accountable? The WHO, I guess it's up to member countries to hold the WHO to account. As I said, they've been criticized for being slightly slow in alerting the world. But a lot of host governments were too slow as well in responding after the alert went out. So there's something about how do we hold them to account. But the other point I guess I think you're trying to make is that with preparations have made and different decisions have been made that would have changed the outcomes. Hindsight's a wonderful thing. Yes, had we reacted much more speedily, had we enacted much more rigorous control measures, yes, outcomes might have been different. Yeah, but we're not out of it yet. So watch this space.
Okay, we have another person, Charles. You asked two questions. I think you've kind of answered the first one a little bit, but his second question was, some of the people infected by COVID-19 won't develop symptoms, and what is the proportion for people without symptoms? Does it vary in different countries? So does the proportion of asymptomatic cases vary from country to country?
Okay, thanks, Todd. That's a very good question. And the answer is we don't know. There's a very wide range of asymptomatic cases from around the world. Some of it is down as low as 10-15%, some as high as 50 to 60%. Okay, so a lot of the epidemiology is emerging from around the world, where we'll start to map out and work out what the true asymptomatic rate is. The problem is not just identifying people who are asymptomatic. Even if you were to test them, it's knowing whether the test was accurate. Remember, I mentioned to you the issue of false positives. So it's really tricky to know, but needless to say, there is a proportion. My guess is between 30 to 40% who are truly asymptomatic.
Okay, I think we have time probably for one more question. Poonam asks, do you think lockdowns are effective? For example, in a country like India, there was a lockdown for about 2 months from March to May, but still the cases are the highest. I think they are the highest in the world. And I think India yesterday had the highest daily total number of cases, didn't it?
Thanks. It depends what your objective is. Lockdown to slow the virus, to buy you time, yes, it works. Okay, it slows down the pandemic to give you time to put in place your disease control measures and get a vaccine. Okay, you might want to do a lockdown to try and eliminate disease, but that would require a very rigorous and prolonged lockdown in order to do that. So that is possible as well. But lockdown as a general measure to keep the disease at bay is not feasible because of the socio-economic impacts. It's just too expensive and costly. Yeah. My personal view, have a lockdown, bring the numbers really, really low down. Okay. Once the numbers are really, really low down, your public health systems with their health protection teams can then continue to investigate and play whack-a-mole and keep the infections low down. So if your infection numbers are very high, lockdown will be useful for that reason. And I'm just looking at the chats there, and I agree with Ian. Lockdowns are an action of last resort. Last option left for a system that's basically failed. Ian, agree with you on that. Okay. Right. So it just leaves me to say thank you all for your time this afternoon. Great for you to join us, and I hope you've heard something new today. Thank you very much.
Okay, thanks, Andrew. We have a couple more of these sessions coming up. In a few weeks' time, we've got Emma Hock talking about the everyday things that shape our actions, the influence of the environment on health behaviour. And then the next one after that will be Dr. Andrew Booth talking about question of who, not if, achieving real impact through qualitative systematic reviews. We'll send around the links later on for the booking to both of those. But thanks so much, everyone, for joining us today. If you want to learn any more about our postgraduate courses, the link is on the screen here. And for general inquiries about ScHARR's programmes, both our taught and research postgraduate programmes that we run in ScHARR, you can contact sharrtu@sheffield.ac.uk. I'll put that in the chat box now. But thanks for joining us, everyone.